Hello. I hope you're enjoying what you're learning so far and taking what you've learned and applying it to your day-to-day clinical practices. We haven't talked a lot about immediate implant placement. So today's case is going to highlight an immediate molar implant placement that I did at my office. I'm going to highlight the steps, the anatomical features in terms of what to look for, and help give you the confidence to do these cases predictably in your office. So sit back, relax, and let's enjoy this quick clinical case about an immediate molar implant placed on the lower right. This was a case referred from my good colleague, Dr. Sony Thomas. I wanted to give him a shout out and just say thank you for the referral. If you're in need of a good endodontist and you're in the Arcadia area, give his office a call or Google arcadiaendo.com. I promise you won't be disappointed. Let's dive in on this case. So, how do we take a case that comes in? Dr. Thomas saw this patient, advanced caries with pulpal involvement on the mesial aspect of number 30, as highlighted here on the clinical radiograph. So, this tooth is savable. I want to make that very clear. However, the need in terms of the procedures that are needed to save this tooth and the predictability in terms of the long-term outcomes are unknown. We have advanced caries with pulpal involvement, limited remaining tooth structure. We need a root canal to be performed on this tooth. We're going to need a new crown, a buildup, and crown lengthening on a foundation that is already quite rocky. So how do we decide in terms of what are we looking for in terms of long-term predictability, not short-term predictability, especially if the patient's going to be paying the same amount? If you're going to be spending a fair amount on saving a tooth, I want the most predictable options for our patient. So in this case, we elected not to save the tooth and instead remove the tooth and place it with an immediate implant. So here's a little sneak peek in terms of how we got from A to B. But let's dive back and let's look at the clinical photos before we got to the end result. So you can see the advanced caries on the mesial aspect of number 30. You have pretty heavy wear facets, especially these non-working wear facets on the lingual cusps of tooth number 30. Adequate band of keratinized tissue, some localized recession. So let's talk about incision design on this. Do we flap this? Do we not? Are we going to try and get primary closure around this case? Are we going to place a healing abutment? Are we going to place a cover screw? All very good questions that will be answered. So when I'm doing these immediate molar cases, here's going to be my incision design to give me best flap adaptation. I'm going to start intrasulcularly on one tooth in front of the area that we're working. So I tend to go to the midline of the line angle on tooth number 28, intrasulcularly around tooth number 29, intrasulcularly around tooth number 30, and I'm going to wrap around until I get to the mid-crestal ridge. Then I'm going to go lingual into the keratinized tissue and then eventually drop a vertical incision. I don't like to drop the vertical at the line angle of tooth number 30 because now I have some tissue to suture to in this area. It makes closure a lot easier with this type of flap design. But let's look at this tooth from an occlusal view. Again, you can see those non-workers. You can see the open contact, which led to the food impaction, which was likely the cause for the caries at that area in conjunction with the heavy occlusal forces. This tooth had a very poor prognosis, both endodontically, restoratively, and periodontally. So remember, when I'm looking at prognosis, I'm looking at it from those three different disciplines to figure out a general overall prognosis for this tooth. But we have to consider each etiology and each treatment modality individually when we're considering the assessment of this tooth as a whole. So I always like to take a CBCT image to map out my IAN, my inferior alveolar nerve. In this case, the question becomes is where do we place this implant? We know it's the distalmost tooth. We can see the opposing tooth at tooth number 3 is an implant as well. So I don't want a lot of cantilever forces to the distal of this tooth. So we chose to elect for the implant into the mesial root of tooth number 30. This is going to give me a nice emergence profile with an ideal result. I could have placed that tooth a little bit, the implant, excuse me, a little bit more distal and angled it slightly more to the mesial. However, because I had this root to work with, I know I'm going to get good insertion torque. I have good buccal lingual bone. So that's why we elected to place that tooth in this position at an ideal depth, about 4 millimeters from the free gingival margin on the buccal aspect. So when it comes to these immediate molar implants, they may be slightly deep when it comes to the comparison of the buccal versus the lingual portion of the bone. I may be countersunk 2 to 2.5 millimeters based off of the curvature or the slope of the ridge. When it comes to the extractions of these teeth, I like to take kind of a three-step process. And my first incision is going to be I'm going to cut the crown off. Why? Because I want to see the roots. And I want to make sure that I'm going to section those roots really well. So if I remove the crown, the clinical crown portion, I'm going to cut through that crown with a surgical burr and elevate or luxate that crown off. Now I have good direct visualization to the roots. Then I'm going to section those roots and then I'm going to start to apply those forces in the appropriate way to remove those roots individually and atraumatically, leaving behind all of the buccal bone. So you can see here, the tooth is removed. All the roots are removed. There was a distal root fracture, so the x-ray was taken to confirm that the root was fully removed. And like we had talked about before, where do we want to place our implant? Do we want to place our implant at site A, as I'll show you here? A roughly proposed implant, not in the appropriate depth, but just my mere teaching point is location mesial distal. That's going to be a long cantilevered force to get that tooth all the way closed and get that interproximal contact closed. So we elected for placing that implant into the mesial root. Remember, I don't need a lot of width with this crown. The average molar size crown is about 10.5 to 11 millimeters. So even if I shorten that up to 9 or 9.5 millimeters, the patient is still going to have good functionality with this implant crown. So again, highlighting our plan again in 3 dimensions. I'm going to be going with a 5.5 by 10 Nobel parallel line. I like the parallel for this case, and I like the width to really engage into the mesial and distal bone at this location. But the one thing I need to be mindful of is I'm going to be placing this implant freehand. I need to be mindful of where that root form is at because of the angulation and the distalization of the root on tooth number 29. So here we are, minimal flap reflection. Implant is placed into that mesial root, and we have good initial torque. Sometimes I will elect for an active over a parallel in this case, but I knew the bone quality was good based off of the CBCT. My preferred implant line is a Nobel parallel. It just works best in my hands. The reason why I elected for a 5.5 is because it comes with a peak abutment, something that's going to give me a really nice emergence profile. That's about 6.5 millimeters wide by about 7 millimeters deep. So you can see from this photo, like we had talked about before in terms of the bone depths, I'm about 4 millimeters from my free gingival margin with a good band of keratinized tissue. But again, look at the difference because of the slope from buccal to lingual. And notice how much deeper I am on the lingual portion. That is okay. But the one thing we need to be mindful of when we're looking here is all of this bone. all of this bone here can prevent the proper seating of a healing abutment. So remember, when you're placing your healing abutment, whether it's a PEEK healing abutment or traditional titanium abutment, it should screw in very easily and then just stop. You shouldn't have to tighten it really hard, right? It should go, go, go and stop. That's how you know it's fitting passive. Otherwise, you're going to be putting pressure necrosis on the bone if you're continuing to tighten it and you haven't alleviated the bone around the implant body. I have a trick to help with that. Now, let's look at this implant again from the occlusal view. So notice how we're lined up right down the central groove. We made our nice incision. So what I can do when I'm closing is I can start to rotate this tissue around and get good primary closure and get that thick keratinized tissue snugged right up to the healing abutment. And then I'll continually close as I move distally. So that was all taken into account when it comes to my incision design. And I'm always thinking about that in the future. So we place our protective bone mill abutment onto the implant. So Nobel makes these bone mills. It comes with a protective abutment, just like a tall, narrow healing abutment. But then what this bone mill looks like is it fits passively over that abutment and you go until it seats fully. So that's what you can see here in the picture is you can see that I'm fully seated from the bone mill on top of the abutment. These are in 1 millimeter increments. So you can see here I'm about 3 to 4 millimeters from the free margin and about 5 or 6 millimeters from the lingual aspect. So again, just all things that are built in that you may or may not be aware of when it comes to measuring these things out when you're working on areas clinically. So with this case, I really wanted to improve the tissue quality simultaneously because I did a full thickness flap design. So this is going to be a 1x2 microderm that is trimmed to size and it's going to be tucked on the buccal aspect on the buccal bone but beneath the tissue. So it's trimmed down. And then what I'm doing is I am grafting that distal root and the mesial root. And my preferred graft of choice is going to be a mineralized cortical creose graft. I like the smaller particle, 0.125 millimeters to 0.85 millimeters. So not only am I I'm placing the bone in, and now I'm placing my microderm in, I'm now using that microderm as almost like a barrier membrane to some sorts, almost like a socket plug, so to speak, to help close and seal the graft here. So the other thing to keep in mind is the timing of the implant as you're putting it in, right? It needs to be in a certain position to allow for this peak abutment, which is more um, rectangular in shape. It's indexed, so it's engaging, right? So my implant has to be timed just right. So you have to be mindful of where that internal connection is. And then we close it up with 5-O-glycolon from osteogenics. And you can see here we got good primary closure, but let's take a look at the occlusal. So in a good position, you can or cannot cover that access if you want. What I like to do is sometimes I'll put in a medium body to cover that plug with no Teflon tape, and it pulls out real easily when it comes to doing your torque test or ISQs at the 4 to 5 month mark to check your integration. But everything's closed up and healing well. Implants at a good depth, but this was the root form that we need to be mindful of sometimes, right? But notice how the interproximal contact is different from that root angulation because it's been crowned in the past. So my crown will have a nice interproximal contact because of the implant positioning. If that crown was a little bit more in line with that root form, I would have tipped this implant a little bit more mesial and had a little bit more mesial angulation to get a good broad molar contact. All things to be considered when placing these molar implants. So here we are at 2 weeks. wonderful healing. That tissue is going to continue to shrink and remodel. We're at a nice depth. We're going to get good emergence. We're going to let this area heal for about 5 months or so. Even though insertion torque was 35 plus Newton centimeters, I tend to let these areas sit for a little bit longer. That's a personal preference. You could go back in as early as 3 months if you wanted to and do your torque test and move forward with final restorations. But all things to consider when it comes to immediate molar implants. So I hope you've enjoyed this case. Today's case was a little bit shorter of a case, but we'll talk a lot more about more immediate implants and tips and tricks along the way to get good primary stability, when to choose a cover screw versus a healing abutment, when are you going to do soft tissue grafting, what type of bone to use, when are we going to use a membrane or not. All of these questions will continue to be answered as you start to see more clinical cases. So thank you so much for joining in. Take that 3-question quiz at the end of this lecture. Enjoy those CE credits, and we'll see you again soon. Thanks so much and have a wonderful day.